Hello, everyone, and welcome to the second World Sepsis Congress. This is the fourth session of the day entitled The Epidemiology of Sepsis. My name is Jeremy Kahn. I'm professor of critical care medicine at the University of Pittsburgh, and it is my distinct honor to be moderating this session. I would like to welcome everyone all over the world. Good morning, good afternoon, good evening, wherever you are. This is a worldwide audience representing over 150 countries, and it's a real pleasure to be here. We have 6 fantastic speakers today discussing what I think is one of the most important topics of the entire Congress, which is the epidemiology of sepsis. Obviously, what cannot be measured cannot be understood and improved, and yet there are many challenges to understanding the global burden of sepsis. And we are fortunate enough to have a number of experts to be discussing this topic today. The way this will work is we'll hear from each speaker. If you do have questions, please type them into the public audience chat, which is on the left side of your screen. I cannot guarantee that we'll be able to get to all your questions, but I'll try to get to as many as possible as this session moves along. With that, it is an absolute pleasure to introduce our first speaker. He is Bin Du, a professor of internal medicine and critical care medicine at Peking Union Medical College and the immediate past president of the Chinese Society of Critical Care Medicine, who will be speaking on national estimates for China. Thank you, and take it away, Bin Du.
Well, thank you, Jeremy, for the kind introduction. And today we'll talk about the epidemiology of sepsis in China. I have no conflicts of interest with regards to this topic. And from the very beginning, we all understand that the Dr. Greg Martin, reported that during the 20 years of period of time, that the incidence of the sepsis has been increased significantly from 80-something per 100,000 population to the more than 240 cases of 100,000 population per year during a 20 years period of time. And in a systemic review conducted by Dr. Reinhardt and his colleagues, that they estimated that during the past decades that the population incidence rate of the sepsis was a 437 cases per 100,000 population per year, that with a global estimates of 31.5 million new cases of sepsis globally, that based on the data from the high-income countries and regions in the world. And how about China, which is the most populous country in the world? And the first national estimates of the sepsis epidemiology in China was conducted more than 15 years ago, which is a observational study, 1 year observational study conducted in 10 surgical ICUs involving approximately more than 3,000 critical ill patients. And the investigator reported that the prevalence of the severe sepsis and septic shock was approximately 9%, with a 28-day mortality rate as high as 45%. And about 5 years later, when conducted a 2 months of the observational study in 22 general ICUs in mainland China, and we reported that the prevalence of severe sepsis and septic shock was approximately 37% of the cases, and with hospital mortality rates of more than 1/3. And however, and when we compare our data with that of the European countries, we can see that the prevalence of sepsis in Chinese ICUs is equivalent to the average rates of that of the European countries. And however, this kind of study have some limitations because it's have inaccurate estimates of the septic cases. And for example, the Dr. Angus and his colleagues reported that at least a half of the septic patients were treated in general wards rather than the intensive care units. And what is more peculiar in mainland China is that we have no knowledge about the population, which is the denominator, because we have a severe problem of the floating, what we call the floating population. Because in the year of the 2017, which is last year, that the according to the Chinese government, the Chinese floating population or the mobile, the migrant population was estimated as the 244 million, or equivalent to 1/6 of the Chinese citizens. So that's why that we have problem with the denominator. We don't know the population the population is. So that's why when conducted a retrospective study, which is the try to investigate the population-based epidemiology of sepsis in a sub-district in Beijing City during a 2-year period. We actually this is a subject, Yuetan subject of the Beijing area, with an area of more than 4 square kilometers, with covering 26 communities, with an adult population of approximately of 130,000 in the year of the 2010 census. And here we can see this. We obtain that the hospitalized information about hospitalized patients from the Beijing Healthcare Insurance Information System, and which is approximately more than 21,000 admissions during the two-year study period. And we by manual review of the hospital records that we identify the patients who developed the sepsis during the hospital stay or hospital admission. And among the 21,000 patients, hospitalized patients, we identified a total of 1,716 patients who developed sepsis according to the ACCP and the SCCM criteria, which is the sepsis 1 criteria, so corresponding to 8.1% of the total hospitalization. And moreover, that this shows that the population-based sepsis epidemiology, or the incidence of the sepsis, categorized by age and sex, which shows that the incidence of the sepsis was increased as the aging of the patients, as well as the male patients have the higher incidence of the sepsis. This also shows that the mortality rates of this sepsis categorized by age and sex. Again, it shows that as aging of the patients, the mortality rates increased significantly. So based on our data, that we estimated that the incidence of the sepsis was approximately 8.1% of the hospitalized patients, or corresponding to approximately 5 million patients every year. However, these kind of these kind of studies have limitations, because it's only the national estimates of the sepsis epidemiology merits meticulous interpretation because it's not representative of the national population. So in the next stage of the study, we actually refers to the help of the so-called national mortality surveillance system, which covers approximately 1/4 of the national population of the Chinese population. So we actually obtain the data from multiple course of the deaths, as well as the population as economy status, as well as the healthcare resources, and more importantly, we identify the cases of sepsis according to the based on the ICD-10 coding for infections as the major cause of the death. And the hypothesis of this study is that if any of the acute infections were listed as the major cause of death in any patients, the patients should be considered as having SIRS or meeting the criteria, the SCCM criteria of severe sepsis, of sepsis actually. And this is the example of this death certificate example. And the next slide show that the previous study showed that based on the previous study that the SD coding strategy has significantly varied significantly in the sepsis epidemiology, which varied about the threefold in the incidence of the sepsis. So that's why when conducted in our study, that we conduct a validation study, which is a cross-section study with approximately 4,000 deaths between the 1 year period, that we showed that our ICD coding strategy had a positive predictive value of 98% with a negative predictive value of more than 80%, which is regarded as accurate prediction. So based on our study, we estimated in the year of the 2015 that the approximately 13% of the national deaths was attributable to what we call the sepsis-related mortality, which is equivalent to more than 1 million deaths in the year of the 2015 was attributed to sepsis. And this slide shows that the mortality is categorized by different age groups, as well as the different regions that ranging from the 33.4 to 132 deaths per 107 population per year in the year of 2015. And in the multi-level regression analysis, we identified that the increasing age and male sex and presence of the comorbidity was associated with an increased sepsis-related mortality in our country, as well as the more years of education, as well as the more a disposable income per capita was associated with decreasing the sepsis-related mortality in mainland China. So we concluded that standardized sepsis-related mortality rate in China was significantly higher than that of the developed countries and varied according to the socio-economic the indexes. And according to our estimates, that the sepsis-related mortality was estimated at the fourth, the leading cause of the death in mainland China, only following about following the cardiovascular, malignancy, and respiratory the causes of death. And so the inclusion we we understand that the sepsis is a common and fatal clinical syndrome in mainland China, although there is a limited epidemiological research in China, and the incidence rates were comparable to that of the high-income countries and regions with mortality rates associated with age, sex, and comorbidity and socio-economic factors. With that, thank you for your attention.
Thank you so much for that incredible overview. I am, in the interest of time, likely to move on without questions, but several things struck me about those data. First of all, simply the staggering number of 4.6 million hospitalizations and 1 million sepsis-related deaths. And it does strike me that in not only very large countries, but also fast-growing populations, it's essential to not just know what the epidemiology of sepsis is, but anticipate it as these mass migrations and mass growth is happening in order to do public health planning. That's certainly a major issue for China and for the rest of the world. Again, thank you again, Bindu, for that excellent talk. We're going to move on to our second speaker, who is Carolyn Fleischmann-Struzek. Dr. Fleischmann-Struzek is a research associate at the Center for Sepsis Control and Care at Jena University Hospital in Germany, and is going to be talking to us about global and national estimates using ICD data. Take it away.
Thank you, Jeremy, for the introduction and the invitation to speak about global and national estimates on sepsis epidemiology using ICD data at the second World Sepsis Congress. Let me start to introduce you to the importance of this topic. Also, sepsis is a major cause of global morbidity and mortality. There is only little data on sepsis incidence. That means the number of sepsis cases related to a country's population in a year, and sepsis death. Data is missing for many countries, leaving many white spots on a world map. Only for a couple of countries, all high-income countries, national data on sepsis epidemiology could be identified in a comprehensive review of current research literature. This is why the World Health Organization urged all its member states to improve the monitoring of national sepsis incidences, in particular based on ICD data. ICD stands for the International Classification of Diseases and is a healthcare classification system by the WHO, providing a system of diagnostic codes for classifying diseases. Codes are assigned at the time of hospital discharge and are collected mainly for billing reasons, but they are also used for epidemiological monitoring or in death certificates to classify the underlying cause of death. A majority of the existing studies on population-level sepsis epidemiology relies on databases of ICD-coded hospital discharge diagnosis. For Germany, for example, we found an incidence of 335 hospital-treated sepsis and 138 hospital-treated severe sepsis cases per 100,000 population based on nationwide DRG data in 2015. Nearly every second patient with severe sepsis, 44%, died in hospital. The incidence of sepsis increased by an annual mean of 5.7% between 2007 and 2013, whereas the mortality decreased slightly from 49 to 44% over time. Similar trends were found in other countries such as the US, where the frequency of hospitalizations with severe sepsis increased from 143 per 100,000 US adults in 2000 to 343 per 100,000 in 2007, which is equivalent to an average annual increase of 16.5%. Overall, in-hospital mortality rates of severe sepsis decreased from 39 in 2000 to 27 in 2007. To determine the underlying reasons of this phenomenon is complex. Biological and medical factors associated with the aging of the population, as well as an increased availability of intensive care facilities and immunosuppressive or invasive medical therapies may play an important role. Above that, coding habits may have changed over time and are prone to monetary incentives. Thus, a progressively more sensitive coding may capture a larger but less severely ill group of patients over time. This phenomenon was described as Will Rogers phenomenon. And yes, to further investigate this phenomenon, Rhee and colleagues investigated this phenomenon in a study and compared estimates for sepsis incidence based on ICD data to estimates based on clinical case identification in electronic health records. They found that between 2009 and 2014, sepsis incidence using clinical criteria was nearly stable, whereas incidence based on ICD data increased significantly, proving that the observed annual increase of sepsis cases seems to result to a considerable degree from improved coding of sepsis. Another interesting fact that this study shows is that there was a considerably smaller case rate of sepsis cases when sepsis was identified based on ICD data compared to clinical data. Only 30.5% of sepsis patients that were identified using clinical criteria in electronic health records received an ICD code for sepsis. In a validation study comparing coding of sepsis in hospital discharge data with clinical sepsis diagnosis in manual patient chart review, we found an underestimation of sepsis cases by up to 3.5-fold for sepsis in Germany. That means the approach of estimating sepsis epidemiology based on ICD data relies on accurate coding of disease. This is why different case identification strategies emerged for the identification of sepsis in hospital discharge data, not only relying on so-called explicit sepsis codes, for which I presented the data so far, but also mirroring the clinical sepsis definition by combining codes for infection and organ dysfunction in ICD coding. This strategy was named the implicit method or Angus amputation and is less prone to coding incentives, but may lead to an overestimation of sepsis cases. A study by Yeski and colleagues demonstrated that there is an up to 3.5-fold difference in the incidence of severe sepsis depending on the method of case identification used. Therefore, the results of epidemiological studies on sepsis may always need to be interpreted in respect to the case identification strategy used. Let me summarize. ICD data are an important source for estimates on sepsis epidemiology, given their comprehensive availability in large databases. Estimates confirm sepsis as a major and most likely underestimated cause of morbidity and mortality worldwide. Given the fact that estimates are influenced by changing coding habits and the case identification strategy used, the assessment of the true burden of sepsis requires improvement of coding practices and further development of robust case identification strategies. Thank you very much.
Thank you so much, Dr. Fleischmann-Struzek, for that fascinating talk. We do have time for a question, and I'm certainly curious. Your data demonstrating the limitations of ICD-9 codes for sepsis epidemiology surveillance are compelling, but you seem to suggest that there's still room for the use of these codes to do epidemiologic analyses, the alternative, of course, being to just abandon the codes and rely purely on clinical screening, which we'll hear about later. do you think then there is a role in the future for ICD-10 codes, or is it time to recognize their limitations and move on in the modern electronic health records towards pure electronic surveillance?
Well, I think there is a room for ICD-coded studies based on ICD coding on sepsis epidemiology, given the fact that many sepsis cases occur outside the ICU, and it's very difficult to capture all these cases in clinical studies or in studies in general when there is no such system as electronic health records in a country. This is, I think, why the WHO underlined the importance of ICD coding to monitor sepsis epidemiology in different nations.
Yeah, that's definitely true. I tend to agree with you about having this important role, particularly outside the ICU. Also, particularly in the outpatient setting. We did hear with the first speaker that we just simply don't know a lot at all about sepsis cases that are seen in the community and are not hospitalized. I wonder if you could comment on what is known either in Germany or elsewhere about the use of ICD codes in the outpatient setting, in the emergency department setting, or even in the clinic as a tool for sepsis surveillance, because even the data that you showed here are largely still limited to the inpatient setting.
This is true. In Germany, we have a really strictly divided system of in and outpatient treatment, and there's lots of insurance data of the outpatient consultations, which may be an interesting source of sepsis surveillance, but to date it is not used for that. But I'm sure that's really interesting data for further analysis.
Yeah, it's definitely something interesting to talk about. If anyone on the webinar has additional questions, we certainly welcome the opportunity to hear them. All you need to do is type them in the left side of your screen into the public audience chat. While we have just a few more seconds, Carolyn, if you don't mind, what is the next step that your group is doing in Germany to sort of move this along in terms of improving? You mentioned a major focus is sort of improving how we use ICD-9 or ICD codes rather, and getting people to be better at ICD coding in order to improve sepsis surveillance. How would you go about doing that? How would you make the coders better?
Well, actually, at the moment, we are trying to find out more about the validity of sepsis coding in Germany. We had a single center validation pilot study comparing estimates for sepsis incidence based on ICD data to manual patient chart review, and we are going to repeat that for in a multi-center trial to better understand which factors, patient factors, or other factors influence the coding of sepsis, and maybe factors that can be changed in order to gain better validity of sepsis coding and administrative data. Sorry?
Oh, no, well, just to say thank you very much. We are going to move on, but this was an absolutely fascinating talk, and we greatly appreciate your time. On that note, we're going to move on to our third speaker in the session, who is Haniffa. Rhee is an intensivist and an anesthetist, as well as a sepsis epidemiologist working at University College in London. And he is going to be talking to us about mapping diseases, sepsis in resource-limited settings. Dr. Haniffa, please go ahead.
Thank you, Jeremy, for that kind introduction. Hello, everyone. Thank you to the organizers for being kind enough to afford an opportunity at this Global Sepsis Alliance meeting. It's a real honor and a pleasure to try and present a little bit of information and some ideas about how we might go about mapping sepsis in resource-limited settings. So maybe just a couple of caveats. perhaps also the reason I have been asked to speak here is because I'm directly associated with a network where we try to improve critical care and acute care outcomes in resource-limited settings. And that's working with the University of Oxford and some non-for-profit organizations. I mentioned that because I'll try and illustrate a little bit of what I think might be strategies using experiences we have directly encountered. So when we talk about mapping sepsis in resource-limited settings, firstly, what are resource-limited settings? And I think we've already had some flavor of what that might be. We've understood that it's definitely not the high-income countries. So we are talking about low and middle-income countries. Sometimes it comes as a surprise to people that that's predominantly the vast majority of people in the world live in those countries. So by some estimates, more than 80% of the world is what we are talking about. It is also a truism that the voices from those places, not only in common with sepsis or other diseases, quite often are not as loud as the voices you might hear from the other parts of the world. That is a phenomenon which is quite universal, but I think it's quite important to remember we are talking about the vast majority of the world. And if you then talk about mapping diseases such as sepsis, I think we've already heard a couple of excellent talks about how the heterogeneity of sepsis between and within countries, within age groups, impacts how we understand and how we try to control and manage sepsis. I would actually propose that this heterogeneity and this variation extends beyond sepsis. And that's something which I think we should also consider, because if you think of acute illness, if you think of critical illness, if you think of the deteriorating patient, whether that is due to sepsis or not due to sepsis, I think these themes still prevail. And I will try and illustrate a little bit about those similarities in my talk, if I may. And if we talk about mapping diseases, I don't necessarily mean just talking about the diagnosis or the causes of that disease, in this case sepsis, because it's important to understand, as we've heard from some of the talks in this session and previously, how the processes of care we use to managing these diseases, whether those patients are managed in high dependency settings, whether they are managed in intensive care settings, whether they are managed in an outpatient setting before they come to the hospital, what kind of resources are available to manage these patients, whether antibiotics are available, vasopressors are available, intensive care is available, whether surgical access is available. And we know from the big drive to improve global surgery how difficult source control access is to a vast majority of the population who live in low and middle income countries. And that also then links directly with the training. What kind of training is available to people who are trying to manage these conditions? I think when we talk about diseases and mapping their prevalence, their epidemiology, we also have to consider what tools are available. For example, whether that is to try and use things like SOFA, whether that's possible to use, how valid would QSOFA be, and I know there'll be some conversation about that. I think it's important to think about this in a more holistic manner. So if we think, what do we know about sepsis, for example, in resource-limited settings? I think we've already seen this slide a couple of times in this session about how the really good quality data about sepsis is limited predominantly to high-income country settings. There is increasingly data from low and middle-income country settings, and I think we'll come to that a little bit later, but predominantly good quality data remains limited to high-income country settings. And then followed by the obvious question, is it necessary? And I hope you will be convinced, as I am, that it is important for several reasons. One is because, indeed, as the vast majority of people live in these settings, it is important to know more about them. Secondly, the heterogeneity, as you might see, whether that is Ebola virus disease, whether that is dengue, whether that is even diseases like malaria, whether that is melioidosis. The heterogeneity needs to be understood. And even in diseases like what you might understand to be traditional sepsis of gram-positive, gram-negative bacterial sepsis, even then the presentation to hospital, whether those people got antibiotics before they got into hospital from a GP, whether they got native treatment, whether they are able to have source control, those things become very important. And I think, therefore, hopefully the case is made that we must understand this heterogeneity better. So and then I think we've also seen this slide from the Lancet Global Health paper. This is a study done by the Oxford unit I'm directly associated with, again showing not only the heterogeneity of the organisms causing sepsis, but how also it is difficult to get the microbiological diagnosis in a vast majority of those patients. Sometimes because microbiological facilities are not available, sometimes because there is a cost implications about doing a culture, which sometimes a clinician feels is not necessary. They treat with antibiotics, sometimes because the patients already had polypharmacy in terms of antibiotics, anti-infectives, anti-malarials before they get into hospital. So if that is the case, then why is the mapping or understanding of these diseases in resource-limited settings a challenge? Again, I hope I don't have to win you over to understand that this is a challenge. The challenges of resources are well understood. The challenges of overburdened clinicians are well understood. The challenges of doing continuous high-quality surveillance and audit in these settings are well understood. But also perhaps what is less understood is the challenge of utilizing the existing information, the existing resources, a little bit like the approach demonstrated with the ICD coding, a little bit like using information which is already available to clinicians, researchers, administrators to try and answer real world questions about the diseases we are encountering. And I'll try and illustrate a little bit of that. Perhaps the frequent challenge which is underplayed a little bit in these settings is the capacity to conduct high quality studies, whether that is observational studies or interventional studies. In addition to the cost factor, the ability to reliably and in a robust manner conduct and conclude these studies in a manner which wins over the local population, rather than them perceiving this as some parachuted interventions which are being tested in that setting, is also a challenge. And these create difficulties for researchers in this setting. So if those are the challenges, then is it all doom and gloom? Is it not possible to address the mapping of these diseases? I certainly don't think so, and I think there's good cause to be optimistic about that. We heard about how the WHO is advocating the mapping of these diseases using traditional and routinely collected ICD coding. That's happening already, and I think it's important to utilize that as much as possible, understanding the caveats that that information is different to what you might get from an observational study or an epidemiological study or a randomized control study. But it is information which is out there and which can be made better and more usable, and I'll talk about that a little bit later. Secondly, I think initiatives such as the Global Sepsis Alliance, and I know there is the African Sepsis Alliance, and there's conversations about trying to have something similar in Asia, which will hopefully promote, advocate some of the work we are talking about in this session. And also, I think there is real interest in trying to use available studies, available data sets to try and answer research questions related to sepsis and deteriorating patients. I know Christina is going to talk about some of the work she has very nicely done from low and middle income country data sets, and that is perhaps a really nice example of how existing information could be used. So what we have done in our experience, in the strategy we have utilized in South Asia, is to try and use the clinical necessity of enabling better information availability for patient care, whether that is in public health settings or in acute care settings or critical care settings. there is a dearth of information availability. Clinicians don't have access to information. I'm just going to go to this next slide and I'll come back in a moment. Clinicians, in this slide, you can see how there are bottlenecks for managing acutely unwell patients in terms of flow of information. These bottlenecks prevent the recognition of deterioration, they prevent accurate and timely referral, they prevent escalation, they prevent post-discharge management, and they limit how clinicians communicate with each other. And also they limit transparency, audit, benchmarking, and how patients and their families can interact and understand this information. Now, we are not talking about necessarily implementing a complicated electronic health record. In many of these places, those challenges remain. But by trying to focus and enable perhaps simple platforms which use basic clinical data, which is already being collected, by enabling clinician-led, locally designed platforms which are tablet, computer, mobile phone based, which make some of the information available already on paper records more digitally accessible, by enabling more validated data entry, by enabling better visual display of that information, whether that is dashboards for the clinician, whether that is dashboards for the administrators, and whether that is enabling that information to be accessible to patients and their relatives. I think make that information available for researchers, administrators to then ask better clinical and research questions. The advantage of doing it in that way is that it makes people buy in to the work we are trying to do. Because the stakeholders are better engaged, they understand the questions you are trying to address are clinically relevant. They understand that these are real world problems you are dealing with. They also understand that you are not focused necessarily on one disease, that you understand that it is the unwell patient who has poor outcomes in these settings you are focused on. They also are encouraged that the data is visible, that they can interact with the data, and that there is no malicious intent to portray countries or settings or hospitals as somehow imperfect. It also means that people get used to having this kind of information, and they are more familiar with interacting with that information. And then the question comes, how might you use that information? And hopefully this slide illustrates a little bit of how that information might be used. So at the top you have a couple of the papers, and I know Christina will be talking about that shortly, but also we have the dashboards which we use to encourage clinicians, administrators, and patients to interact with these patients with infection who have organ dysfunction, and how you might improve their care processes. So in summary, I'd like to think the mapping of diseases, whether that is sepsis or any patient who's acutely unwell in resource-limited setting, is important. And it's important when we are trying to map these diseases that we understand there are different approaches, whether they are studies, using routinely available data, or using information platforms such as ours. But I think perhaps by putting those together, there's an opportunity to influence and interact with these diseases in a more realistic manner. Thank you, Jeremy.
Oh, that was absolutely fantastic. Thank you so much. The challenges here are immense. One question that came over the channel was about the biggest challenges in these low and middle income countries compared to high income countries. So obviously, sepsis surveillance is a massive problem even in wealthy nations. What do you think are the top one or two problems facing low and middle income countries that need to be dealt with to start raising the bar in those areas?
Thank you, Jeremy. I think that's an excellent question. Quite often people focus on the things which are obvious, I think, which is like money, training, and so on. But I think we find the biggest challenge is engagement. even when you try to get this kind of information, when it's real time, when it's usable, when it's clinical, administrative, patient information, to get people to engage with it in a manner that they believe in, and then to get people to use the information in a manner which impacts patients on the ground, I think is the biggest challenge. I will not claim that we have the answers to that, but I will say that we are closer to the answer than we were when we started. And it's really exciting that we are able to get such movement, to get patients and families interested in that information. And perhaps that's an avenue for progress.
That's fascinating that even in the era of technology, that it's these low-tech solutions like clinician engagement that are the key to getting unbiased answers. I think that's particularly true in low and middle income countries because of the risk of bias, because if only the highly motivated hospitals and health systems are participating in these surveillance activities, then you do get a risk of bias. I'm sure that Christina is going to mention some of these later. Thank you so much again. With that, we are going to move on to our fourth speaker, who is Rhee. Dr. Rhee is Assistant Professor of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare. He's not only an intensivist, but an infectious disease physician at the Brigham and Women's Hospital in Boston. And he is going to be speaking to us on national estimates of sepsis using electronic health records. Dr. Rhee, take it away, please.
Great, thank you very much. We'll go ahead and get started. I have no disclosures. So I'll start by talking a little bit about what's been known about sepsis epidemiology. So many studies have been published demonstrating a rise in sepsis incidence over the past several decades. And most of this has been done using administrative data. And there are two major strategies to capture sepsis using administrative data, the so-called explicit sepsis codes, which generally use codes like severe sepsis or septic shock or septicemia, and what's been called the implicit set of sepsis codes, which uses infection and organ dysfunction codes. And both of these have trade-offs in terms of sensitivity and specificity. More recent estimates in 2009 demonstrated that the incidence of sepsis nationally ranged from 900,000 to 3.1 million using 4 different administrative methods. But you can see that all 4 methods demonstrated a rise in incidence. Similarly, using 4 different methods, the mortality of sepsis ranged from 12 to 26%. But again, from 2004 to 2009, all methods demonstrated a decline in mortality rates, which has generally been attributed to improvements in sepsis care. However, there are several limitations of administrative data for sepsis surveillance. So as those prior slides show, different administrative definitions yield quite different estimates of the incidence and mortality. And the administrative definitions generally have low to moderate accuracy relative to medical record reviews, with again, trade-offs depending on which definition is used in terms of sensitivity and specificity. But very importantly, diagnosis and coding practices are also changing over time. And this is a result of increasing awareness and recognition of sepsis. There's also been increasing emphasis on documentation. And it's impossible to ignore the fact that there are financial incentives to code for higher complexity. This is a study we published a couple of years ago where we used national administrative data to look at hospitalizations with infections as a primary diagnosis from 2003 to 2011. And we showed that sepsis or septicemia codes were being increasingly used, in fact, almost a 3-fold increase over this time period. But when looking at the infections that most commonly lead to sepsis, like pneumonia, intra-abdominal infections, urinary tract infections, or bacteremia, those are all stable or in some cases actually decreasing, suggesting that part of this may be a shift in how infections are being coded more towards sepsis. So what my colleagues and I over the past couple of years have been working on is conducting clinical surveillance using electronic health records. So instead of administrative data, we have been asking, can we track clinical indicators of sepsis using more consistent and uniform criteria, looking at markers of presumed infections, the cultures and administration of antibiotics, with concurrent organ dysfunction, things like vasopressors, mechanical ventilation, changes in baseline laboratory values. And some of our early work in our local academic hospital showed that this was both feasible and accurate compared to medical record reviews. This led to a project that was funded by the Centers for Disease Control and Prevention, where we had a multi-center study with a goal to create an objective sepsis surveillance definition based on clinical data that can be applied across different EHR systems, and then to apply this definition to diverse hospitals from across the U.S. to generate what we felt would be more credible estimates of the current national sepsis burden and recent trends. So when we developed the surveillance definition, we started with a sepsis 3 framework of infection plus organ dysfunction, but we adapted this to facilitate wide-scale retrospective surveillance. And so we focused on criteria that were objective, routinely measured or used to treat sepsis, and easily ascertainable from different EHR systems, and able to be applied consistently and uniformly. The definition we came to consensus on was this. So we looked for markers of presumed serious infection, so blood cultures being obtained, and patients being treated for 4 or more antibiotic days. Fewer than 4 days were allowed if the patient died or was discharged to hospice or another hospital before 4 days elapsed. And then concurrent acute organ dysfunction, things like, again, initiation of vasopressors, mechanical ventilation, doubling in creatinine, doubling in bilirubin, a decrease in platelets, or an elevated lactate. And we had standardized rules for calculating baseline laboratory values. So just showing this again briefly, the surveillance scheme basically would look for a blood culture, and then would look for a plus or minus 2-day window around the blood culture, look for the initiation of antibiotics that were then continued for 4 days, and concurrent organ dysfunction. And those were labeled sepsis episodes or sepsis hospitalizations. So we had a cohort of 409 U.S. hospitals from 7 different data sets, and compared to all AHA or American Hospital Association hospitals in the U.S., you can see that the distribution in terms of geography, hospital size, and teaching status was fairly representative. Our major focus for the study was the year 2014, in which we had 2.9 million adult encounters, or about 10% of all U.S. adult hospitalizations. The major findings were this. So we found about 174,000 sepsis cases in adults, which translated into a 6% of all hospital admissions. 87% of those were present on admission compared to 13% hospital onset. Over half of these patients were admitted to the ICU. 17% of them had positive blood cultures. 15% of them had septic shock as defined by vasopressors and elevated lactate. And 15% died in hospital. And the mortality for hospital onset sepsis was almost twice as high for sepsis compared to sepsis present on admission. This table just shows the demographics and comorbidities of the sepsis patients we identified. And the main highlights are this. Most cases occurred in patients that were 60 years old or more. About 60% occurred in males. There was diverse racial and ethnic representation. And chronic comorbidities like diabetes, lung disease, heart disease, kidney disease were quite common. When delving into the discharge disposition of these patients, above and beyond just death or alive, we also found that 6% of these patients were discharged to hospice, which means that more than 1 in 5 sepsis patients either died or were discharged to hospice. Half of them were discharged home, and almost a quarter were discharged to non-acute care facilities like rehab. We also looked at all the patients in the cohort who died, which is about 2.5% of all study patients, and 35% of those patients had clinical indicators of sepsis. So in other words, of all patients that die in the hospital, more than a third appear to have sepsis. We then used a table. We then stratified our estimates by stratifying hospitals into region, size, and teaching status to generate estimates of sepsis across the whole country. And this resulted in our estimate of approximately 1.7 million adult sepsis cases in the US in 2014 with 270,000 deaths. We validated the surveillance definition relative to medical record reviews using sepsis 3 criteria as a standard. And you can see in this column here on the left that the definition is not perfect. There is no perfect way to capture sepsis, but the sensitivity and positive predictive value compared very favorably to administrative methods of explicit sepsis codes or implicit sepsis codes. Lastly, we applied this data to the hospitals from 2009 through 2014 to look at incidence and mortality trends. And using administrative data, again, the incidence appeared to rise steadily each year, consistent with many prior published studies. But when using EHR data with more consistent criteria, the incidence was relatively stable, a slight trend towards an increase, but not very much. Similarly, when looking at short-term mortality defined by in-hospital death or discharge to hospice, there was a steady decline using administrative data. But when using more stable clinical criteria from EHRs, there was only a non-significant trend towards improvement over this time period. So in summary, we found that sepsis is common, approximately 6% of adult hospitalizations, translating into about 1.7 million US cases annually. It's deadly. More than 1 in 5 sepsis patients died or were discharged to hospice. Sepsis was present in more than 1/3 of all hospitalizations that ended in death. It potentially contributes to 270,000 US deaths annually. Sepsis trends have been mostly stable from 2009 to 2014, and clinical data contrasts with administrative data that suggests rising incidence and declining mortality, which is likely biased by increasing sepsis awareness, recognition, and coding. And EHR-based clinical surveillance is accurate. Again, it's imperfect, but it is better, appears to be better than administrative data. And lastly, just pointing out that CDC has translated the surveillance definition into a toolkit named Adult Sepsis Events Toolkit, and it is online now with the goal to help hospitals that are interested more objectively track their sepsis rates and outcomes using EHR data. So that's it. That's all I have, and a lot of acknowledgments here. So thank you for your attention. Happy to take any questions.
Thank you, Chanu. That was fantastic. What an unbelievable effort to coordinate this, and you and your colleagues are just to be congratulated. It's simply daunting for those of you who don't know how hard it is to work with some of these records. If you don't mind, I'd like to ask you what I asked Carolyn Fleischmann-Struzek earlier, which is that given your findings and the findings of others, is it just time to abandon ICD codes as a method of sepsis epidemiology research and surveillance, or is there still a role for ICD-9 or ICD codes rather, as these electronic tools that you are proposing become more prevalent?
That's a great question. It's a little bit of a loaded question. I guess I'll give kind of a answer, which I think it depends. I wouldn't say they should be abandoned altogether. I mean, clearly, as you pointed out, I mean, this was a lot of work, and it is, it takes reasonably sophisticated EHR data and people who know how to program to be able to implement this. So there are obviously those logistical challenges, and obviously administrative data is cheap and it's easy and available. I think we just have to be careful with how it's used. So I think when trying to study trends over time, I do think that is a big problem, and I think we should be very skeptical now of studies looking at trends and incidence and mortality using administrative data. I also think, we didn't go into this in this particular study, but I think when trying to compare hospitals based on sepsis rates or outcomes using administrative data, I think that's also potentially very limited too, because we know that there can be a lot of variation in how sepsis is diagnosed and coded between hospitals. So I think for those purposes, it can be problematic. But I think, again, for other type of studies, if you want to just identify a cohort that likely had sepsis and you want to look at various aspects of their care, then using administrative data with sepsis codes, it's not a bad way to go, because we know that they generally do have pretty high positive predictive value. Again, the problem is just the changing practices over time in terms of diagnosis and coding, as well as the variability.
I think that's a nice assessment, sort of like if you, as long as we understand the limitations and are prepared to address those biases, then, no data are not worth using. It's just sort of going in eyes wide open. But allow me just one more question then. You do the question arises, like, we don't have a good reference standard. We don't know for certain whether some of these patients have sepsis, and you will agree, and I completely agree that with the benefits of electronic screening, but as you state, they're imperfect. So I'm curious then, why, what are the biases, right? If we're exchanging one set of biases for another set, what are the biases with electronic data that we have to be concerned about? So when we go to make temporal evaluations, or when we go to make cross-hospital comparisons, we can still go in eyes wide open.
Yeah, that's a great question. So yeah, definitely EHR-based surveillance has limitations. And I think some of the ones that would jump to my mind is, so even though I think it's more consistent over time, it is relying on indirect proxies of sepsis. So, and some of those are based on clinical decisions, which can certainly be variable across clinicians, or perhaps even the threshold for some of these can change over time. So a good example that always comes up is initiation of vasopressors. We know that, again, you and I might have a slightly different threshold for starting pressors, and also we know that the trend in terms of fluid resuscitation and when to start vasopressors, that has changed over time as well. I'll also point out the lactate component. Tracking lactate has some challenges as well, because a lot of QI initiatives will focus on increasing lactate testing rates, so that can introduce some biases as well. So those are the things that would jump to mind, and definitely we have to be aware of that as well when using this method.
Wonderful. Well, thank you so much, Shani. That was fantastic. We're going to move on to our second to last speaker, who is Adam Linder. Dr. Linder is an associate professor in infectious disease at Lund University Hospital in Sweden, as well as a fantastic sepsis epidemiologist, and he is going to be talking to us about national estimates for Sweden based on chart review.
Thank you very much. I'm very happy to be part of this fantastic event, and I will tell you a little bit about a study that we conducted and published 2 years ago. It was work from my colleague Lisa Melhammar, where we did an estimate of the sepsis incidence for Sweden based on a chart review. As we have heard from the other excellent talks, the sepsis incidence based on ICD code or ICD code abstraction have been somewhat various, and there are no clinical data except from ICU wards. And in Sweden, the case is that only approximately 10% of the sepsis or septic shock cases end up in the ICU. As we heard from Dr. Fleischmann-Struzek, there is a great vary in the sepsis incident depending on how you code it. So what did we do? We performed a retrospective review of medical records for all patients who were started on intravenous antibiotic therapy at hospitals on 4 different dates, evenly distributed over the year in 2015 from 2 provinces of Sweden. The 2 provinces comprises 1.3 million adults. That's about 16% of the adult Swedish population, and it's served by 11 hospitals. So the trick here was that in Sweden, if the physician wants to prescribe and institute antibiotics, he or she has to pass this anti-infection tool. It's a national database which registers all out and in patients who are started on antibiotic therapy. So there is no way to circumvent this if you want to prescribe antibiotics in Sweden. So we use this anti-infection tool to identify the patients. And we used quite strict definitions of infections, and also the definitions of sepsis and organ dysfunction. We looked at both the sepsis 2 definition and the sepsis 3 definition, somewhat modified to be adapted to wards, since in the wards you don't always have the PaO2, so we used also the saturation and calculated the PaO2 using the Ellis equation. So the results, we included we scanned the chart for 557 patients, and 438 patients were included. In 99 of those, we could not find evidence of infection, despite the fact that the patients were given an intravenous antibiotics. So we excluded those, leaving 339 patients. And for 109 of those, at 32%, they fulfilled the definitions for the sepsis 3, and for 96, that 28% of the patients fulfilled the criteria for the sepsis 2. So this is equivalent to an annual incidence of patients receiving intravenous antibiotics for diagnosed infections of 2,425 per 100,000 inhabitants. That's equal to 250,000 Swedes per year. And the annual incidence for sepsis 2, we found to be 687 per 100,000, and slightly higher, but not significantly higher, for sepsis 3, 780 per 100,000. This is not age adjusted though. So we found, not surprisingly, that the sepsis 2 and sepsis 3 does not find the same patients. There are somewhat different cohorts. Just looking at the demographics, we could also see here that the sepsis incidence is higher from the age of 65 and upwards. Approximately 25% of the patients had no comorbidities, and approximately 20% of the patients developed nosocomial infection, hence were not community acquired. The difference in sepsis 2 and sepsis 3, you all know this, but it's more common to have a cardiovascular dysfunction according to the sepsis 2 definition, and it's easier to have a respiratory dysfunction in the sepsis 3 definitions. And the mortality for these two groups were approximately between 26 to 32%, and 20% of the patients had a positive blood culture. So this study, the strength, what we think is that we identified all patients treated with intravenous antibiotics in all different departments, different clinics in 2 entire regions of Sweden. That's emergency department, medicine, surgery, oncology, ICU, and so on. And we identified both community-acquired and nosocomial sepsis. And we meticulously reviewed the charts, and it was done by 2 independent infectious disease physicians. So we think that the data has quite high quality, though the study was small and retrospective. If we look at similar studies, there are some studies that have shown similar incident numbers. One is the study by Henriksen from 2015 that looked at only ED patients, medical ED patients, and found 456 per 100,000, and also the study presented here by Rhee previously, and Donnelly. So to conclude this, we found that the sepsis incidence in Sweden was higher using this chart review than using ICD codes. And up to 30% of the sepsis cases were nosocomial, and not surprisingly, the sepsis 2 and sepsis 3 definitions to some extent extent recognize different patient groups. Thank you very much.
Thank you, Adam. That was an absolutely fantastic talk and really nicely complements some of the earlier work we see. It also, from my perspective, just highlights the immense challenge of doing sepsis epidemiology, even in relatively wealthy, developed countries like Sweden. I'm wondering if you could just reflect a bit on the challenges you faced in this study and think about how you might go about upscaling this work to get a better sense of what the population estimates are in Sweden. How could you go about broadening this incredible effort? Because it just seems like even in the somewhat small scale, it was indeed an incredible lift.
Yes, it was a lot of work. In Sweden, we have our national sepsis group. So I have actually thought of, dividing the work on. In Sweden we have 26 provinces. So if we could, divide this work all over Sweden, that would of course give more validity to the data we have. Because we fully acknowledge that the study is small, but we did not see so much difference between the different. We took one date in January, one in April, one in July, and one in October, and it was slightly higher sepsis incidence in January, but quite similar over the year.
Over the period, right? And what do you know about those? I was really struck also that about a third of the patients in your sample had no comorbidities, but yet got sick enough in order to have to receive IV antibiotics. What do you know about those patients, in particular, their outcomes? That seems like obviously a very relevant population.
Exactly. The mortality rate for the whole group, for the 90-day mortality rate, was 32%. Or 26% according to the sepsis-3 definition, but the mortality was higher among those with comorbidities. But other than that, that was patients with pneumonia, skin and soft tissue infection, and urinary tract infection. So there were no difference in the focus of infection or if they had bacteremia or not, depending if they had comorbidities or not.
Right. Let me bring in a question from earlier in the session related to the time frame by which we look at mortality for sepsis patients in these epidemiologic evaluations. So you chose 90-day mortality, which could be argued is very far out, and particularly in a developed nation is very hard to follow patients, or rather in a low and middle income country, is very hard to follow patients for 90 days. Yet, on the other hand, you don't want too short a time frame. How did you settle on 90, and what do you think the sort of right number is?
That's an excellent question. We actually presented the in-hospital mortality as well, and that was 20%, and the 90 days mortality was 30%. Using the sepsis-3. So, I'm not sure. From my understanding, the trend is going towards a longer follow-up, since we know that sepsis patients do not do well in the long term. So maybe in developed countries where you have the possibilities to follow patients for longer, I think it's relevant to look at 1 year mortality as well. But that's my opinion.
Yeah, I think it's really interesting. I think it behooves us as the scientific community to report all these numbers, right? Knowing that a low and middle income country is not going to have a 90-day or 180-day mortality, and also knowing that in-hospital mortality might mean something very different in different countries. For all these studies, we need to be careful about reporting all of these numbers to allow comparable, facile comparisons across groups. Well, that was absolutely fantastic. Thank you, Adam, so much. We're going to go ahead and move on to our next speaker, who is Christina Rudd. Christina is at the University of Washington in Seattle in the United States, but soon to move to my own institution, the University of Pittsburgh, to join our faculty. She's doing some really incredible work that she's going to share with us now related to the topic of challenges to assess the global burden of sepsis. Christina, please go ahead.
Hi, I'm Christina Rudd, and I'm going to be talking today about the challenges we face in assessing the global burden of sepsis. And I'm going to be using a project that I'm currently helping to lead as an example of this. So first, I want to give you some background information on the Global Burden of Disease Study, or GBD, because this is a vital component of the project that I'm going to be presenting to you today. So the GBD study is produced on an annual cycle by the Institute for Health Metrics and Evaluation, or the IHME, in Seattle, Washington. And it's a massive effort to quantify the comparative magnitude of health loss due to various injuries and diseases. And all of their estimates are stratified by age group, sex, and geographic location for specific points in time. Their estimates focus on all aspects of health loss, including mortality and incidence, which we're going to be estimating as part of the sepsis project that I'll be sharing with you. But they also produce estimates on prevalence, disability-adjusted life years, years of life lost, etc. So this is an example of data output produced by the GBD study. So GBD includes over 1 billion data points. And it primarily focuses on underlying causes of premature death and disability from more than 300 causes, diseases, and injuries. They produce estimates for more than 195 countries around the world, and many of those countries have estimates at the subnational level. So this figure is one example of data output from the GBD study. This is a plot of the relative burden of causes of death globally for all ages and both sexes in 2016. In blue, you can see the burden of deaths due to non-communicable diseases. In red, you can see those due to communicable diseases or maternal or neonatal conditions. And in green, you can see those deaths due to injuries. So the goal of this project is to estimate sepsis incidence and mortality for every age group, sex, location, and year from 1990 through 2017. And all of our estimates are going to be stratified across those greater than 300 underlying GBD causes. So while GBD has previously exclusively focused on those underlying causes of health loss, such as pneumonia, this is a new, really novel endeavor where we're producing estimates in parallel to the GBD study and separate from the GBD study, really focused on intermediate causes of health loss, such as sepsis. So here's a visual representation using mortality as an example, just to emphasize the fact that we're producing sepsis estimates across all of the GBD causes. So that means that we'll produce sepsis estimates for patients who are classified as dying from a communicable disease, such as pneumonia, but also for patients who are currently classified as dying from a non-communicable disease like lung cancer or an injury, such as a road traffic accident. So I just wanted to give you a really high-level kind of summary of what methods we're using. So one of our main principles really is to maximize our leverage of the GBD analytic infrastructure and their data sources because they're just so rich and so powerful. So we're using one of the main GBD principles, which is that of envelope, where we're imposing rigorous and evidence-based upper bounds on our estimates to avoid overestimating the burden. And as I mentioned, our sepsis estimates really are separate from the GBD study, but they're very much in parallel to the GBD study and are quantitatively related. And I'll be happy to answer questions about how our estimates are linked to the main GBD study a little bit later on. The cornerstone of our methods is the multiple cause of death analysis and multiple cause of hospitalization analysis. So those are our data sources. And our modeling strategy to help us produce estimates for locations for which we don't currently have data incorporates the Healthcare Access and Quality Index, or HAQI, as a covariate. HAQI is a composite indicator of healthcare access and quality that's independent of geographic location. So I'd like to briefly walk you through our methods as a way to highlight some of the challenges that we've encountered. So this is an international death certificate. If you look to part 1, you'll see 4 slots, A, B, C, and D, where clinicians or coders list the causes of death for an individual. Slot D is the underlying cause of death, and that's what's largely used by IHME to classify the cause of each death. But slots A through C are intermediate and immediate causes of death, and those give us data on other conditions that contribute to that death, such as sepsis. So one of the challenges is, therefore, we need data sources that have at least 3 codes listed in part 1 of the death certificate. And I'll show you in a minute why we need 3 codes and not just 2. But we absolutely can't use death certificates that only have 1 code listed, that underlying cause of death. And unfortunately, that's what we have for the majority of the world. So how are we going to identify cases once we have these data sources? Our case definitions come from the sepsis epidemiology literature, and we've modified them for the purposes of our study. They largely draw from the Angus criteria, for those of you who are familiar with those. So these are mutually exclusive categories. First, we look to see if an individual meets criteria as an explicit sepsis case or explicit sepsis death. This means that a sepsis-specific ICD code is listed in slots A through C of that death certificate, so an immediate or intermediate cause of death. So, for example, if a patient has R65.2, which is the code for severe sepsis, that patient would be classified as a sepsis death. If a patient does not meet criteria for as an explicit sepsis case, we look to see if they meet criteria as an implicit sepsis case. So this means that a patient has a specific infection ICD code listed as the underlying cause of death, so that's slot D on the death certificate, and in addition to that, they have a specific organ dysfunction ICD code in the chain of death. So, for example, if a patient was listed as having acute appendicitis as their underlying cause of death, and then in addition to that had acute respiratory failure listed as an intermediate or immediate cause of death, we would capture that patient as a sepsis case. So there are a few challenges here. First, these coding systems, such as the Angus criteria, have really been used in a lot of population-level sepsis epidemiology studies in high-income countries, but their validity is largely unknown in low- and middle-income countries, tropical countries, with different infection profiles and populations. So we've done our best to modify the Angus criteria to really represent that global infection profile and be globally applicable, but we acknowledge that this system has not previously been validated in those settings. So another challenge that's maybe obvious to you at this point, and has been a big hurdle for us, is that obviously if something's not written down, we can't capture it. So the presence of sepsis and the presence of organ dysfunction needs to not only be identified by a clinician, but also needs to be recorded on the death certificate or in the hospital admission or hospital discharge administrative records in order for us to capture that case. We can't make up codes that aren't already there. And unfortunately, what we're finding is in a lot of places, these things just aren't written down. Another challenge is that these coding systems, such as the Angus criteria, are almost exclusively used in hospital administrative data. Again, these are hospital discharge and admission records or billing records. And I'm really only familiar with one paper out of the CDC that looked at the performance of these ICD-based coding systems in death certificates. And so really this is largely uncharted territory, and we are really looking forward to future validations of the methods so that we are better able to kind of calibrate our results in these different sets of data. So all of those challenges being what they are, I wanted to show you some of the input data that we're using for our mortality and our incidence estimates. So on the mortality side, we have access to over 100 million individual death records from the United States, Brazil, Taiwan, and Mexico across all of these years. So this is fantastic, but it's also a major challenge because we're trying to produce fractions or sepsis estimates for the whole world based on just a few countries. On the incidence side, where we're using our hospital records, we do have a few more countries for which we have data and a few more years, and we have nearly 300 million individual hospitalization records. But again, these countries are a far cry from the whole world. So in summary, the challenges that we're facing as we're trying to produce estimates for the global burden of sepsis are many. At the bedside, clinicians and coders need to not only recognize but also record the presence of sepsis specifically, or at least the presence of organ dysfunction in the setting of infection. At the population level, public health systems and countries really need the capacity to compile the multiple causes of death data and multiple causes of hospitalization data, and then we need them to be willing to share that data with the Institute for Health Metrics and Evaluation so that it could be used as part of this project. And then lastly, within the sepsis epidemiology community, we need our colleagues, all of you who are listening, to help us validate these coding systems in more diverse populations and settings and infections. And we also need to look at how valid our coding system is in multiple data sources, such as death records and not just hospital administration data. So with that, I want to acknowledge my fabulous colleagues, both at the Institute for Health Metrics and Evaluation, as well as the members of our advisory board for the GBD Sepsis project. And I'm happy to answer any questions.
Christina, that was fabulous as always. Thank you so much. I have so many questions, but we just have time for a couple. One sort of larger conceptual issue when I think about GBD is that causes of death are not mutually exclusive. The original GBD output graph you showed us did, though, have them listed as mutually exclusive groups. You either die of lung cancer or breast cancer. But with sepsis, it's a unique syndrome, right? It's you can die with lung cancer and sepsis, and multiple people do. So how is the GBD project thinking about sepsis when it's not a disease per se, but a critical illness syndrome that can span multiple diseases?
Yeah, that's really the crux of why this project was created. That's a great point, Jeremy. So yes, the mission of the GBD study is to classify every death as due to one underlying cause. And they try to go as far upstream as possible. Well, this due to this, due to this, and what was that ultimate underlying cause? And that's how the whole GBD study operates. And so what makes this project novel is really, for one of the first times, we're looking at GBD data and saying, okay, well, what else? What else was in that chain of death for the patient, and was sepsis specifically in that chain? And so the GBD will, in future cycles, be adding in other processes, not just sepsis, to kind of take a similar look at their data and say, okay, well, what else is there as an intermediate cause of death or disease? So, for example, they're going to be doing this with antimicrobial resistant infections and saying, all right, so this patient was classified as dying of from their diabetes, but what was the more intermediate or immediate cause of death here? And was it something related to AMR?
Christina, one last question for you, which is really, I think, I'm interested in your perspective, having engaged the GBD project, but it's something that has sort of been an undercurrent of this entire session, which is why do this, right? I think that largely the people on this webinar and the people who are participating in these sessions have drunk Kool-Aid. But when we go out public health experts, when we go out to our hospital administrators and say it's crucial that we invest resources in better understanding sepsis epidemiology, what's the right answer? Like, what can we tell them is going to be the tangible benefit to society by doing these sort of large scale but quite expensive epidemiologic studies?
Yeah, that's a great question. I really think about it in terms of who's going to be using the estimates that we produce and how it will be changing things for the people that actually have sepsis. And at the health system level, so health system administrators, public health professionals, those that are looking at distribution of funds within health systems, those people really need data to help inform their allocation of resources. And in some settings, those are pretty scarce resources. And so, while it's important at, let's say, the infection control level or the epidemiology level to know exactly what bug caused the pneumonia and how many cases of pneumonia caused death in a given location, and that's what we're getting from the GBD data, at some point, really, we want to know how many ICU beds we need, or how many patients are going to need supplemental oxygen, or how many bags of IV crystalloid need to be ordered. And these are common resources that are necessary for sepsis patients. And so if we can provide estimates for sepsis incidence and mortality, people that are planning the care of these patients will have more data to help organize those kind of common threads in those patients' care.
Yeah, that was an incredibly great summary. Thank you so much. This has been a wonderful, wonderful session. I think everyone will agree. It was certainly a treat for me to hear from all these experts from across the world in really a unique format that can bring all of us together. I want to thank all the organizers of the World Sepsis Congress, in particular the program chairs, Flavia Machado, Simon Pinfer, and Conrad Reinhardt, and the Global Sepsis Alliance. I'd like everyone on this call to remember to, if possible, participate in the GSA Global Quality Measures Survey. This will just take a few minutes. It's completely anonymous, and it really is an essential next step to understand how sepsis is measured and treated around the world. There's a link on your screen for you to get some additional information about how to participate in this survey. And with that, I'm going to conclude this wonderful session. Again, thank you to everyone for participating. Please do not miss the next session. If you can, join it. Session 5, Improving Early Detection and Quality of Care. Again, thank you to all my speakers. Thank you to the Global Sepsis Alliance, and thank you to all the sponsors who are there present on the screen for making such a wonderful event possible. Goodbye, everyone.